السلام عليكم. محاضرة راح تكون حول mastering one lung ventilation، أي استعمال one lung for anesthesia and other lung for the surgery. So, at the beginning we have two lung. One will be the ventilated lung dependent and the other lung is non-dependent lung. The ventilated lung dependent, it is optimal oxygenation, healthy flow of the oxygen and CO2, and there is no ventilation perfusion mismatch, or the ventilation perfusion match is normal, stable, compliance. While the second one, there is shunt hypoxia, so that is the difference between the first one and the second one. And the second one, the non-dependent, that rectus intrapulmonary shunt, hypoxia risk, decreased compliance, potential alarm. What is the indication of one lung ventilation? First, for surgical exposure, so any surgery need to do in one lung, it will use one lung ventilation. To facilitate video assistant, thoracoscope surgery, thoracotomies, by creating vital physical space within the chest cavity. The second contraindication, contamination control, to prevent contamination from one lung to other lung, and to protect the healthy lung from cross-contamination caused by purulent secretion or infection or massive hemorrhage originated in the dressing in diseased lung, and to prevent ventilation distribution. Provide absolute precision and control over airflow distribution when bronchopleural fistula, large air leak, or giant pulley are present. So this is the main three indication for the one lung ventilation. What about the ventilation perfusion mismatch and the shunt? It is a very important issue in this kind of type of anesthesia. You can see that لاحظون, this is the non-dependent lung. There is only perfusion, but there is no ventilation. While the second one, it is ventilated and good perfusion. So, if we do a comparison between the first one and the second one, in the first one, which is the ventilated lung, there was an increase in airway pressure, forcing intertidal volume into a single less compliant lung. So we must decrease the tidal volume to prevent an increase in intra thoracic pressure inside the lung. So it is better perfusion for gravity, but reduce compliance and decrease functional capacity. While the non-dependent lung, the shunt lung, perfusion without ventilation, decreased PaO2, severe hypoxemia risk due to unoxygenated shunted blood, and the PaCO2 is and the CO2 is increased. Respiratory distress regarded with Bohr effect. So, what is the lung isolation device selection? There is two mechanisms of isolation. The first one is the double lumen tube. It is two tubes sending the oxygen to the right and to the left. While the second one, bronchial blocker, it is direct. The tube go to the loop or to the bronchial. So, mechanism for the double lumen, it is two separate lumen, tracheal, bronchial, allow completely independent ventilation. Best for indication, versatility, standard open thoracotomy, massive lung hemorrhage. So this is very important because we must isolate the first lung from the second lung. Speed of collapse, it is rapid, immediate. While primary drawback, high risk of malposition, frequent reposition required during surgery. في بعض الأحيان تغير position of the tube, so it is very important to check the reposition of the tube. While the bronchial blocker, balloon catheter passed via standard single lumen tube and inflated directly inside the target bronchial. In this scenario, we need to use fiber optic video laryngoscope to ensure that the bronchial blocker inside the position what we wanted. أي إنه إحنا نتأكد 100% إنه التيوب البرونكيال تيوب موجود بالمكان اللي إحنا نريد نسوي له بلوك. Non-difficult airway, existent thoracotomies or selective lobar isolation. Slower, gradual lung collapse, easily displaced, total losses of isolation if deflated or re-inflation. And then again, very important, the position. What is the golden rule of placement? Continuous visual verification is non-negotiable in thoracic anesthesia. نتأكد 100% from the double lumen in proper position. So up to 80% of a blind double lumen tube placement result in malposition. So first we secure the airway. Please standard double lumen or single lumen tube with a bronchial blocker. Fiber optic conformation. We sure that is the tube in a proper position, and very important in bronchial blocker. When we change the position of the patient to lateral position, again we check our tube. Mandatory recheck a tube. Invertibly shift reconfirmation with the scope immediately to prevent contamination. Initiation and conduct of one-lung ventilation. Procedural excitation and expected physiological shift. First, pre-oxygenation. Increase FiO2 to 0.51 to maximize oxygen reserve prior to collapsing the operating lung. So we give increase the FiO2 to collapse lung to the non-dependent lung. Second, isolate the airway. Club the lumen corresponding to the operative lung. So we close the lumen to the non-dependent lung, physically stopping ventilation to the side. Then there will be no ventilation when you clamping the lumen of the non-dependent lung. Third, adjust ventilation parameter. As we know, that is the tidal volume will be degrees when we use in double lumen tube or one lung ventilation because it is increase in the pressure inside the dependent lung. So we decrease the tidal volume. 4. We monitor peak pressure. Very important to monitor the peak pressure. Keep airway pressure minimum. High pressure risk of causing air leak, paratrauma, and worsening exciting fistula. انتبه هنا نقطة جدا مهمة إنه نحافظ على البيك airway pressure in minimal side لأنه if it is increased this will lead to diffuse and paratrauma. Hypoxemia troubleshooting flowchart. في بعض الأحيان in one lung ventilation hypoxemia will be happened and is detected. So what we can do? Manipulate dependent lung. First, bronchoscopy check for exact tube position. النقطة اللي جدا مهم إنه نتأكد التيوب مالتنا in proper position or not. 2. Section the clear secretion and blocks, because sometimes the secretion will block the dependent lung and this will lead to decrease the oxygen level. Apply PEEP to the dependent lung, to ventilated lung, but optimum PEEP, because if we increase PEEP or high PEEP, it will divert the blood to collapsed lung worsening shunt. What about the collapsed lung, non-ventilated lung, non-dependent lung, the lung for the surgeon? So apply CPAP, oxygenated static airway without full re-inflation, insufflate pure oxygen directly, surgical clamp to pulmonary artery, extreme measure to physically halt the shunt. طبعا هاي النقطة الأخيرة جدا مهمة. في بعض الأحيان كل البروسيجر اللي ذكرناها عملناها للمريض مالتنا لكنه the oxygen it is not increased. So now we will ask the surgeon to clamp the pulmonary artery to the non-dependent lung. This will improve the condition of the patient. Thoracotomy versus video assisted thoracoscope surgery. طبعا ما يمكن إجراء العمليات بالطريقتين open thoracotomy أو الفاتس اللي هي video assisted thoracoscope. For open thoracotomy, highly invasive approach with high anticipated blood loss. إذا هاي العمليات يكون عندنا blood loss عالي جدا بيها. Pulmonary risk, high post-operative risk of atelectasis and pneumonia. Pain, it is high pain. It is severe acute pain require excellent regional anesthesia, epidural or paravertebral block. it is carry 25 to 60% risk of chronic post-thoracotomy pain وهي نقطة جدا مهمة. While the video assistant thoracoscope surgery minimally invasive, faster recovery, reduced post-operative pain, and less blood loss. Anesthetic trap, despite smaller incision required identical complete one lung ventilation, hypoxemia risk remain just as severe as open surgery. So مشكلة الهايبوكسيميا ما زالت موجودة على الرغم من أن احنا استخدمنا الفيديو assistant thoracoscope. So from the side of hypoxemia there is no difference between both methods for open or the video. Surgically apply rescue CPAP to the non-dependent lung by partially re-inflate it actively running the surgeon camera view. Red flag. طبعا توجد حالات خطرة جدا احنا during thoracic anesthesia اللي هي when we do mediastinal mass surgery for mediastinal mass. Why? A critical circumstance where standard rule are surprised by immediate life threat. First, total cardiovascular collapse and airway obstruction open induction of the anesthesia. نقطة جدا مهمة. إذا تشوفون that is mediastinal mass. باللحظة اللي احنا ننطي بها anesthesia we will lose the muscle power and this is lead to complete cardiovascular collapse. So what we can do first, maintain spontaneous ventilation. Why we maintain spontaneous ventilation? Because paralysis remove crucial chest wall tone leading to immediate total airway collapse under the weight of the mass. 2, we can do awake intubation. Secure the airway using awake fiber optic approach before administering induction agent. يعني بالبداية احنا we will do awake fiber optic intubation and then we will give the induction of the anesthesia. Standby rescue اللي هو a bronchoscope, a rigid bronchoscope must be ready for any abnormality and if cardiopulmonary bypass may be needed sometime. So, the one lung ventilation, master clinical map, high yield synthesis and exam focus. The threat. الخطورة وين تكمن بعمليات ال one lung ventilation أو الدبل لومن endotracheal tube. Shunt lead to hypoxemia. So, dependent lung suffer poor compliance. إذا الديبندنت لانج المشكلة non-dependent الديبندنت لانج suffer poor compliance. Non-dependent lung drop FRC enter. What about the double lumen? The gold standard when we use beta blocker, always remember to check by fiber optic. 100% mandatory fiber optic confirmation. Rescue under risk, hypoxia, in case of IO2, apply CPAP to non-dependent lung, apply PEEP to dependent lung. Surgical risk, thoracotomy, severe pain, and we need epidural pain management. To ventilated lung CPAP, to VATS, CPAP may run surgical exposure. In the VATS, very important, we use CPAP. And in the mediastinal mass, cardiovascular collapse risk must be keep spontaneous breathing. So again, to remember the PEEP in dependent lung and CPAP in non-dependent lung. إلى هنا تنتهي المحاضرة.